hand it over to Joan.
Okay. Well, hello, everybody.
Hi.
It's a pleasure.
Sorry, Joe. I was going to introduce you, but you can jump right in.
No, go ahead.
Hi,
Introduce.
this is Joan King, and I just wanted to, some of you I've met. I work at the National Council and am doing a lot of work in Montana around integration projects, both with the state and with the Montana Healthcare Foundation. Just a quick word about questions. Since this is a 30-minute webinar and we'll try to stick to that time frame, we probably won't have a lot of time for questions, but we will answer questions that you type in. We'll get back to you with answers to those, and also feel free to email me after the webinar, and Joe and Carlos and I will work on putting together some answers to your questions. And with that, it's my pleasure to introduce Dr. Joe Parks, who manages to make this topic interesting and has many other claims to fame, which I think he'll share with you, but I'm just delighted to have Joe with us. I learn something every time I hear him speak. So, Joe, I'll turn it over to you.
Okay, thank you so much, and let's see if I can figure out how to advance my slide here. Show me where my slide advancer is. I'm sorry.
I think if you just click on the screen, it should be good to go.
Okay.
Carlos, you may still have control of the slide, so why don't you go ahead and advance it?
Okay, yeah.
So to give a little background on myself, I'm the Medicaid director in Missouri. For the previous 20 years, I was medical director with the Department of Mental Health. I still see patients on a weekly basis. I'm a practicing psychiatrist. I see them in a primary care setting at a federally qualified health center. Go ahead. I'll start with a brief history, and I'll talk first about HIPAA, but actually 42 CFR is much older than HIPAA. 42 CFR applies only to substance abuse treatment, not to substance abuse diagnosis or the fact that somebody has a condition, but to providers that hold themselves out to the public as providing substance abuse treatment. The law was actually passed in 1972, before I got out of high school. The regulation was promulgated in 1975, the year I graduated high school, and it was last revised in 1983. 42 CFR Part 2 has not been revised since before cell phones hit the market and when most of us weren't using computers. HIPAA and its major focus was to encourage people to seek treatment. If you remember, that's when the war on drugs was the public policy craze, and we thought we could stop substance abuse by locking everybody up. That's been a failed strategy, and people were very worried about any knowledge about their substance abuse problem would land them in jail, have them lose their job, and they'd be heavily discriminated against. So 42 CFR is all about keeping everything secret so people won't be scared. HIPAA was not enacted until 1996. It was intended as an administrative simplification and was not intended to particularly, it was actually to make things easier to share information is the base intent of HIPAA. The reg was published in 1999, and it was actually revised as recently as 2013. So it is much more current with the current state of healthcare. Go ahead. So HIPAA is designed to deal with personal health information, PHI. It really pertains to all personal health information, so that would include substance use disorder treatment. And health information is information that's individually identifiable. It can be past, present, or future health care. And it comes in 3 buckets. It tells us how to handle information for the purposes of treatment and operations and payment. And it handles treatment substantially different than operations and payment. Go ahead. It's individually identified, meaning you can tell the specific identity of the person. Go ahead. And as I said, there's 3 buckets: treatment, payment, and operations. One more ahead. Treatment means the provision, coordination, or management of a healthcare condition and related services. And that and related services is important. By one or more healthcare providers, this can include things like coordination or management of healthcare with another party, consultation between healthcare providers related to a patient, or referral. So treatment covers referral. Go ahead. Actually, authorization is not needed to disclose PHI for treatment purposes. You can disclose PHI, personal health information, absent consent. HIPAA allows it without consent. It's by design broadly, it's intended to be broadly defined, and it covers coordination and management among providers that have a provider relationship or where there is an intention for a future provider relationship, which is how referrals included. It also can cover related services. I'll say more about that in a moment. Go ahead. Related services can include social, rehabilitative, or other services associated with healthcare. Probably the most common one that occurs are people that are in disability-specific housing. So if you have patients that are in housing they would not be able to be eligible for without a disabling healthcare condition, that housing is a healthcare-related service, and their treatment information can be shared with that housing provider to the extent it's necessary to support and assist them with their healthcare condition. Go ahead. Treatment is all about individuals. You cannot release group information. It's about individual release of information. It can be about a prospective patient in the case of referral. Minimum disclosure does not apply. You can really disclose everything you know. You don't have to hold it to the minimum for the purpose. The only thing it does not apply to is therapy notes. And by therapy notes, we mean the old-fashioned process notes like you would see in psychoanalysis that go on for 5 to 8 pages about what they thought next, what was in their dream, blow-for-blow descriptions of emotions and actions. A therapy note is not a brief note that says, met with the patient to discuss issues related to family conflict, reframed relationships, diagnosis of depression. It's not those very brief office-related notes. It is much more detailed psychological notes. Treatment, the following is considered treatment. Case management is treatment. Care coordination is treatment, disease management, health promotion, outreach programs, all the things that you do in a person-centered medical home or a health home for chronic condition. Healthcare operations is the second big bucket. It includes quality assessment, improvement, staff evaluation, insurance-related activities, administrative function. It's really how you run the business end. Go ahead. And in general, it's activities that support treatment and payment functions. It is usually about groups of patients. It's usually a population-based activity. And covered entities, meaning healthcare providers, may use any personal health information that it maintains for operations. It also can be disclosed without authorization, but you only disclose the minimum necessary. So if you are managing large groups of patients, you don't disclose their whole history. You do just enough for the purpose of that one management or operations. Go ahead. The following things, when they're population specific as opposed to individual specific, can still be healthcare operations: case management, care coordination, disease management, health promotion, and outreach. This means that you can share information related to, if you're looking for everybody, if you want to do an individual interventions on diabetes, but you don't know who to pick out, you can select everybody with a diagnosis of diabetes, then maybe just look at their ER and hospitalization visits, but you're not sharing their whole treatment record. You then pick out the 20 sickest you want to focus on, and then you share the rest of the record. Go ahead. So you can exchange files with limited information under healthcare operations, and then later exchange the rest of the information based on the specific individuals you've selected. Payment encompasses the various activities that get you payment. Go ahead. Includes determining eligibility, risk adjustments, billing, collection, renewing, reviewing services, and utilization review. Go ahead. Payment is only individual. Payment is not a group population activity. Covered entities can disclose PHI regardless of HIPAA status for the purposes of payment, but you disclose the minimum necessary amount to execute the payment. Go ahead. The surprising truth about treatment is that although individuals have the right to request a restriction on how you use their PHI, you are not required to agree with their request for a restriction. So if you write your policy saying that we share PHI for the purposes of treatment because care coordination is good and leads to better quality care, you can actually share PHI even over patient objection, as long as that's your stated policy and you notify people ahead of time. So even if they say don't share, if it's provider to provider for the purposes of treatment, it is allowed under the federal HIPAA regulations. Go ahead. If you're sharing with external entities, the covered entity is the healthcare provider that has the personal healthcare information. A business associate could be another healthcare entity, or it could be a company that's helping you with operations, a company that's helping you with payment, a company that's helping you with staff training. Go ahead. A covered entity must comply with HIPAA. Covered entities include health plans, a healthcare clearinghouse, or a healthcare provider who transmits any health information in electronic form. Written forms covered also. Go ahead. It can get kind of complicated here, but you can be a single covered entity, or you can set up what's called a bubble rule and form covered entities consisting of multiple entities. That's beyond the scope of this call. But if you're doing some tight regional coordination, it's good to consider that, and we can do more technical assistance on that at another time. Go ahead. A person or entity that performs the function of the covered entity should have a business associate agreement. It lists what can be shared with who and the manner in which it can be shared. Go ahead. However, it's not required for sharing information for treatment. A business associate agreement is only required for health operations and payment. You should not go writing a bunch of business associate agreements if you're only sharing individual patient information for treatment purposes. But with the BAA in place, then you can share information for health operations and for payment. Go ahead. So that is the fast, high-level background on HIPAA, which covers all healthcare provider operations. And the thing to remember is treatment is broadly defined, including it allows for sharing information under referral. It allows for activities like care coordination, case management, that it does not require patient consent. You should not adopt individual institutional policies requiring patient consent because you are bound to your own policies. So if you have a policy that says we only release it with consent, then that's what you better do. You should write a policy that says we share personal health information for purposes of treatment when it's in the best interest of the patient, and then proceed to do that and take the best care you can with them. Specific to substance abuse treatment, it comes under 42 CFR Part 2. The interesting part about this old act from 1973 is it's very short. The regulations are very long, but the act itself is very short, only 474 words. And in statute, there are only two requirements that are stricter than HIPAA. You do have to have patient consent to share anything, and you can't use any of the information for criminal charges or investigation unless there's a substantial risk of death or bodily harm. All the other restrictions that come with 42 CFR are in the regulation, which is much broader than the underlying statute. When it comes to HIPAA and substance use disorders, regulation is much broader than statute. And actually, these regulations are under review, and we're hopeful that a much improved version will be finalized in the coming months. The additional requirements beyond HIPAA is you do have to have consent. It has to be for a specific purpose. It has to be to a specific organization. It must be time limited. It is for only the minimum necessary for that specific purpose, and you can't redisclose it. These causes huge barriers because if you start incorporating 42 CFR covered information in your clinical record, then you have to be careful how you release your clinical record. If I get from a substance use treatment disorder that my patient has been in substance abuse treatment and I put that in my evaluation note, now I have problems if I want to show my evaluation note to somebody else, because I have to take that one little piece out. So it creates huge barriers that impede care coordination and good care management. Go ahead. It is generally disclosure of information that identifies a patient directly or indirectly as having a current or past drug or alcohol problem and having treatment. So if you are when I am in my primary care practice that does not advertise publicly that it does substance abuse treatment, it does some incidental to all the other problems, but it does not have an ad in the paper or on its website saying that Family Health Center is a substance abuse treatment provider. So actually, those kind of practices, ERs, hospitals, general medical practices, federally qualified health centers, unless you advertise and hold yourself out to the public as doing substance abuse treatment, you are not a covered entity that falls under 42 CFR. If you do hold yourself out publicly as being a substance abuse treatment provider, then then all the substance abuse treatment information is subject to the 42 CFR additional restrictions unless they consent in writing. There are other exceptions, next slide, including written consent, of course, medical emergency. You can share it with a qualified service organization, which is kind of like a business associate agreement. That's another company that's helping you deliver that care. There are limited releases for research that also require consent, internal communications, if there's a crime that actually happens in the clinic. If you blind it, it's audited, if you're court ordered, or if you're reporting abuse or neglect. Go ahead. And of course, HIPAA is much broader than 42 CFR in that it allows disclosure without consent in the cases of individual treatment. Go ahead. So the problem with 42 CFR, it was designed to protect people, and it might have been somewhat useful at the peak of the war on drugs, but we're kind of past those days, and it actually harms more people than it helps right now. It kind of depends where you sit. If you are a lawyer and you're dealing with the legal consequences of somebody's been discriminated against because people didn't like their substance use disorder, you may be more concerned with protecting all that information. If you are a medical practitioner or an emergency room doctor, you're much more concerned with sharing information because you see all the overdoses that come in and the people dying because information wasn't shared. Go ahead. 42 CFR disadvantages people that have substance use disorder because if I want my care coordinated, I have to anticipate what care I will need from who in the future, so I could put my consents in. I have to update any expired consents so my care can continue to be coordinated. And in general, I won't get that extra attention and support that providers give to any patient with a chronic disorder. If my primary care physician knows that I've had blood clots in my legs, and I come in and I'm going to take an airline ride, they'll tell me to get up and walk more often. If I come in short of breath, they'll think about clots in my legs again before they think about asthma, allergies, or other causes of shortness of breath. Similarly with substance abuse, if my provider knows I was successfully treated in the past and I come in complaining about insomnia and irritability, they're more likely to ask me if I'm still in recovery, if I'm still abstaining, if my alcohol and drug use is still abstinent or under control. And it really denies people that extra early intervention, and it prevents healthcare systems from arranging high risk and high utilized supports for high risk and high utilizer patient groups. Go ahead. It disadvantages the substance use providers. They have the expense of constantly updating and redoing consents. They have extra expense of an electronic medical record that can track and manage the complicated requirements. And more importantly, they have the public relations costs as being seen non-responsive and obstructive by other healthcare providers. Go ahead. And overall, it tends to keep the substance use disorder treatment system small and isolated. General care health providers are less likely to add substance use treatment. They're less likely to partner because of the burdens and difficulties of coordinating care. Health information exchanges are all waiting till later to work out how they manage this data, the information on substance use treatment, and just avoiding it. So it ends up excluding the substance use providers and the conditions from care coordination and care management initiatives. Proceed. It really is a major contributor to the deaths by methadone. Methadone is the 30% of prescription overdose deaths. The death rate from methadone is 6 times higher in the last 10 years. Buprenorphine abuse and overdose are rarer, but they are increasing in number. Go ahead. Prescription drug abuse has become a national epidemic. And while individuals who have received specialized substance abuse treatment are less likely to abuse prescription medications than people that have not gotten treatment, they are more likely, they are at increased risk of relapse compared to the general population that's never had a substance use disorder, and some subsequently died of prescription drug overdose. Go ahead. Segmented consent has not worked. There's been efforts to build clinical records where you can keep track of all these different consents, but of course at the end of the day somebody has to enter all the new information, and that's a lot of staff time. Proceed. So in general, 42 CFR means that the patients and providers miss out on better electronic medical records, health information exchanges, prescription drug monitoring and improvement systems, care coordination, and population management. The one thing I would advise is they should be hooked in so at least they can consume the information, even if they can't put outgoing information in. Proceed. The best way to minimize the harm due to 42 CFR is if you're not a covered entity, if you don't hold yourself out to the public as providing substance abuse treatment. So if you have a diagnosis of a substance use disorder, but you don't advertise that you treat substance abuse, then you're not subject to 42 CFR, and it's fine to share those diagnoses. The common example is somebody coming into the emergency room intoxicated or in withdrawal. Emergency rooms are not substance use disorder providers, and that information can be shared. Treatment of substance use disorder by providers who don't hold themselves out to the public are not subject. I write a lot of prescriptions for naltrexone, and I counsel people on their alcohol use disorders in my clinic in a primary care clinic. However, since I never advertise that, neither does the primary care clinic, it's just one more piece of treatment we quietly do, I'm not subject to 42 CFR. Treatment of medical complications of substance use disorder are not the same as treatment of the disorder itself and do not fall under 42 CFR. So the best recommendation I can give any agency is you should provide integrated care that includes substance abuse treatment, but you're best not to advertise that you provide substance abuse treatment. So you should integrate the heck out of it so you do it all the time, but don't put a sign out so you can actually coordinate care and share information. Proceed. Same covers for medication. If you don't hold yourself out to the public as providing substance abuse treatment, then the medication you prescribe does not come under those restrictions. And I want to point out that a number of states won't report anything about methadone because they know that a little bit of methadone is used for methadone maintenance treatment. This is kind of a blunt approach. The only methadone that is legal to use for methadone maintenance treatment is the liquid methadone. So actually you can share information about the 98% of methadone prescriptions that are in tablet form and used for chronic pain. And that's where most of the overdoses comes from anyway. So that might be something you might take a look at in Montana. You're making sure to only pull out the information on liquid methadone and not all forms of methadone. Proceed. So, you know, the reg is being revised. It's not yet been released, so now would be the time to tell your delegation that you would like to see 42 CFR as consistent with HIPAA as statute allows and applied as narrowly as you can, except we should definitely retain the prohibition on use in investigations or for criminal charges. Go ahead. I won't go through the rest. It's more on how to rewrite the regulation. I think at this point, I'll throw myself open to questions.
Thanks, Joe. And I know that was a very quick trip through really important topics. for a Friday afternoon. I don't see any questions, so this would be your moment to jump
Well, then I
in.
have one more moment. Then I do have one more point I want to make for anybody on the phone, for anybody on the phone that is a CEO or a manager or one of the risk managers. You need to review your 42 CFR and HIPAA training to make sure it emphasizes how information can be shared. Often these trainings emphasize all the ways you shouldn't share them, and they end up sounding to the poor person taking the training like they should never tell anybody anything. And you need to make sure that your staff trainings on HIPAA and 42 CFR emphasize that the purpose of these regulations is to allow information to be shared, especially HIPAA. And you know, if you've been overly zealous in warning about all the bad things, you're really doing a disservice. I frequently see these regulations overinterpreted. You know, I frequently give this talk to large audiences of several hundred people. I did just earlier this week, gave this talk to about 300 people, and I always ask for a show of hands of how many know anybody that's actually had a fine or a penalty for HIPAA. I've never gotten a hand. I once got a hand in 5 years. And they wouldn't tell me any details about it, so I'm not even sure if they're telling the truth, but they said they knew somebody. I then asked for a show of hands of how many people know somebody that's been hit by lightning, and I usually get several. You are more likely to get hit by lightning than to get sanctioned with a HIPAA violation. So do the right thing, coordinate their care. It'll make them healthier, they'll be safer.
Okay, now I've got a question here, Joe. Thank you, and I'm glad I've heard you say that, and I'm glad you said it today, because I think that's a really important emphasis that we often miss. Okay, so here's the question. Related service is a broad term. Can this include public health departments, youth support services, and other social services?
If it is a service related to the medical condition, I think you could certainly assert that. It is worth taking the position. Like any regulation, there are things you clearly can do, things you clearly can't do, and then there are areas of gray in between. I always think when you're in a gray area, you should do the right thing and worry about whether it's somebody else thinks it's black or white another time. Certainly for public health information, we are sharing public health information with medical practices, and our medical practices are sending public health information into the public health department. I think that's an easy one. We have found housing very defensible. If people are in a service that they could not get without a medical condition, that's a related service. If they would be ineligible if they did not have a medical condition, it's a related service.
Thank you, Joe. And it is 4 o'clock. Well, no, it's not 4 o'clock for you guys in Montana. For Carlos and for me, it's 4 o'clock on the East Coast, 3 o'clock for Joe, and 2 for all of you. So I want to thank all of you. We had great attendance at this webinar. I want to thank you for being with us. Remind you that you can send your questions in either to Carlos or to me, and we can get to Joe wherever he is. We can find him and track him down. And then want to also say to all of you, I hope you have a wonderful, I think, last official weekend of summer. So enjoy the weekend, and thanks so much for the work you're doing for the people of Montana. Bye.